Discuss your health, and this morning we're focusing on this the situation in our health sector, squarely looking at maternal health, the situation right now and some of the failures that are leading to a service provision that is not satisfactory or to the level that is needed in our local communities. And we'll be breaking down data that came out of a research that was done in our local hospitals, just to shed light on what is happening at the local community level at the hospitals and how we can better improve service provision, even though we are going through some very difficult time. And this particular research was done by Contrast, QData and UNDP, all coming together to shed light on what's happening in Kenya as far as health provision is concerned. And my guest this morning shall be Peter Ngure, who's a contraceptive lobbyist, policy and advocacy team leader when it came to this, the team that went through this research, as well as Akako Ekirapa, who's a senior reproductive health advisor when it comes to this particular exercise that happened. Now, to bring context to that and give you a snippet of what was found out through this research, let's take a look at some of the numbers that have been highlighted in that particular research. So it focuses on Nairobi, and we're told here the population growth rate here in Nairobi is 2.2% per year. According to this research, 681 is the number of health facilities that serves the population in Nairobi, and 115 of those are government owned. And given the situation right now, you can expect that 115 of those are not offering any medical services. And in Nairobi, NHIF Linda Mama is the predominant cover. Then it is accepted in 42 private hospitals and accepted in 134 government hospitals. Now, at this moment, then you can expect that 134 facilities are not offering this. And even as you dig into that report, you find that it was not, it found out that not everyone knows that they can actually get that cover that has been dubbed Linda Mama. And then we have infant mortality rate. We're told 55 babies die out of every 1,000 live birth that is given. So that is quite high. Let's move on to another set of information. We have under 5 mortality. We have 72 per 1,000. It goes even higher. So as they go along, some time after they're given, they get into the world, some of them actually die off. And some of the causes, when you look at the report, are quite causes that can be done away with. So we shall be digging deeper into that, as well as the maternal mortality rate. Currently, according to this report, stands at 212 per 100,000. Now, I will welcome our guests to the conversation. Welcome to the show, Peter and Akako.
Thanks for having us on board.
Okay, so let's just dig deeper into, or let's set the stage. Why did you decide to do this? What was this report? What was the motivation behind it when you're going into the field to find out about service provision? I'll start with you, Peter.
Thanks. For the last 10 years, we have had the devolution of health services, and so it's a culmination of a long process where we were looking at, so after the 10 years, what has been the misses and the gains that have been achieved in, especially in maternal health, but more so to look around the issue of service delivery and see how much are the services being offered to Nairobians, right. And especially so for Nairobi, because the population in Nairobi has really grown. And so we were looking at, do the same infrastructure, do the same number of health workers that were there in 2010 able to deliver in the promise of devolution in 2020.
Okay. Now, I'll give it to you, Akako, if I'm not mispronouncing your name. And when you went into the field, what did you encounter? And from your perspective, what is the thing that stood out, particularly when it comes to maternal health care? We've seen the mortality rate right there. We've often had one death is too many, but then we're told about 55 per 1,000, 72 per 1,000. What to you stood out?
Yes, thank you. My name is Akacho.
Akacho, so, okay.
Yes, so just like Peter mentioned, what was quite surprising was actually, it is not only women in the informal settlements who face challenges accessing maternal health care, but even the middle class. And one of our key findings was one woman can actually spend between 7,000 to 8,000 shillings just for one visit. And as much as we recommend the government for the Linda Mama program,
yes,
many women were complaining they would go with the card to the facility and the facilities do not accept the card. We also had a session where we tried registering with the number, but some subscribers also mentioned they were not able to log on.
Right.
So what we would like to say is the findings highlight the challenges women face across, and probably as we advance towards universal health coverage, the Linda Mama program should consider the challenges that were talked about in this study.
Okay, so UHC is basically meant to bring access to healthcare for all, based on distance or access in terms of physical access as well as in terms of cost. So, Peter, when it comes to how much has been done to gain that, because it's part of the Big Four agenda that was, everyone was raving about it a few years ago. So when it started off, there was an uptick, according to the report, in the number of people that were going to hospitals. Has this been sustained, or has there been challenges in ensuring that we keep up with access, better access to healthcare, particularly for mothers?
When UHC started, it had the promise of upscaling, and UHC is all about affordable healthcare,
yes,
not really free healthcare. But the push by government was that it's more of a free provision, and in the pilot counties, which Nairobi was not one of them, they were able to give free access and free cards and free services to people. But with time, because the first phase was meant to improve the infrastructure of those facilities, people have been going to level 3 and level 4 facilities and neglecting level 2 and level 1, because then service provision and the package offered in the higher level facilities is a bit better, and government invested more in that. And we saw that government moved from 6.9% in its national budget for health to about 9%, which is below the Abuja declaration, which should be 15%.
yes.
But they really had a little bit of improvement. But at the same time, there were challenges like security for women, because women will not go to a facility, even if it's 24 hours, if it's in an area that is insecure. So looking around things that are more than just infrastructure and health system, but going more to what do women want when they find in the facility. And those were the few challenges we identified around UHC.
Few, but not quite small. Now, when it comes to FMS, the free maternal services, apparently it shifted from that to now Linda Mama, but then there's quite a considerable level of ignorance about this being an available option for many, particularly in urban settlements. Dig into that, Ms. Kacho.
Sorry, I didn't get the question.
When we had FMS, the free maternal services, at least there was more publicity around it. But then it shifted to Linda Mama, but then there's a considerable lack of knowledge about it. Could you tell us about that and what you discovered when it came to the knowledge when amongst people who this is meant to benefit?
Yes, so what we found, there were two issues. One, we had two different types of people we're interviewing. So one were the service providers. And according to them, their issue was when the free maternity services rolled out in 2013, there was a big upsurge of women attending the health facilities. And this was very good in terms of improving our indicators for Kenya. However, their challenge now came in terms of reimbursements, with some of the people even saying they were only refunded about 80% of the services that they spent for delivery. On the other hand, when we talk to the women who access the facilities, particularly those lower ones that Peter is saying, the level 2 and level 3, they said, one, they were not even aware about the service because we as the researchers had to show them now the flyer and explain what services are offered.
By Linda Mama.
Yes. So this is antenatal care. Some family planning services are provided, and also postnatal care services.
Right.
And then, secondly, there was that issue of when you visit the facility, they were not sure when the card would be activated because you were told it will be activated between 3 to 6 months. So there were those challenges also at the facilities.
Yeah. So in the wake of these challenges, let us explain to the viewers how this now feeds into the mortality rate. And at the same time, could you draw a comparison? Because I saw the numbers. When you draw them, a comparison between the numbers in Nairobi and in the rest of the country, you find that there's a significant difference. In some instances, even more people are affected in Nairobi as opposed to the rest of the country.
Yeah, so thank you for pointing that out. One interesting finding was we had one of our respondents from Garissa County saying if you looked at, since devolution started, if you look at the indicators for Garissa, you can see the maternal health has improved.
Yeah.
And this is also because the county government is significantly investing in ensuring mothers are able to come to facilities, creating awareness in the communities, and also providing access to these services. So for example, in Nairobi, as Peter mentioned, if someone is living in the informal settlements, facilities close at 2 p.m., 3 p.m., you can only go to the big facilities. Getting transport is a challenge, and also the insecurity. So we noted that some of the counties in the rural areas had even better indicators. Mm-hmm. And I'm sure we'll discuss later the political interference between Nairobi Metropolitan and the county government. So because of the lack of releasing funds, the county also mentioned they could not deliver the services required.
Actually, why should we wait? Let's go into it. Explain to us. And yeah.
Yes, so we have around 7 billion shillings allocated in the financial year 2019-2020 towards the Big Four agenda in Nairobi County. However, when we were having our dissemination forums for this study, the county representatives noted that money had been stuck at the City Hall, and this is likely because of the leadership challenges that are ongoing.
Yes.
And so they said a lot of the facilities were not able to get the services they need, like commodities. Some of the staff also complaining. For example, in the COVID area, some don't have the PPEs they need. Many facilities also would have to refer clients if they needed additional commodities or if they needed services like scans or other high-level facilities. So it was a challenging from both ends, from the service provider and also from the women accessing the facilities.
Absolutely. And now with having a situation whereby far from those challenges that have been pointed out, we're having some of the issues that we often face, such as corruption affecting service delivery in the medical sector, particularly in Nairobi. So Peter, could you dig deeper into what you found out as far as corruption and some of these scandals that have been largely publicized in the media are concerned?
Yeah, then just to mention that when we were looking at when we were doing this study, then Sonko was still the governor for Nairobi, so he had not released, he had not signed off the new budget for Nairobi. Now the budget has been signed. The challenge with government is that it takes about a month for funds to move from treasury to the county treasury, then to the department. So it delays. There's a lot of delays in the processing of the monies. But this is what leads to the corruption bit around health services, because then some facilities are quicker to go and, let's take the example of Linda Mama. Those private facilities, the ones we mentioned, which are actually the larger number of facilities in Nairobi, because out of the 681 facilities, through Nairobi, only 115 are government. The rest are private.
Yes.
But if you look at Linda Mama, those that are private are able to do their returns quickly and are able to submit their returns faster than government facilities, and so they get their reimbursement faster. But of course, there is also the issue of who do you know at the reimbursement point. And so we found out that government facilities would always complain that their money was not released in time. But if you look at the county level, at the Department of Health level, they had gotten the money, but the money was not reimbursed to the facilities. We couldn't find where the money was taken to. But this also brings to the effect that Nairobi doesn't have a Facility Improvement Fund Act. The fact that money generated by a facility cannot be used at the facility. It has to go to Treasury. And so getting money back from Treasury is a whole process that is rigged with a lot of, you should know someone so that your funds are processed a bit faster.
Basically corruption. Now,
Yeah.
when it comes to that also, let's talk about prioritization, because when you mentioned the shift in how leadership was being handled at the Nairobi County, we did see changes happening in the county in various areas. Would you have preferred, based on what you discovered through this study, that more priority be put on healthcare delivery?
Yeah, true. For Nairobi, it's been a challenge because even currently they're investing about 26% of their annual budget to health.
Yeah.
And whereas they should be putting about 30 to 35%, meaning their priority for health is a bit low. But with NMS, we have seen a shift because NMS is building the 24 new facilities. So we are looking at national government funds going directly to the county functions.
Okay.
We're also looking at them employing 2,400 new healthcare workers. So that's a plus that has been added by the national government. But the county government by itself, with the budget it has not really prioritized health by putting, if the national government adds the 24 facilities and the 2,400 health workers, then it means to be investing about 4 billion into the county health services, meaning we will get about 35% into health in Nairobi. If the county government can put 35% by itself to health, then we would make progress.
Yeah, and when you look at the details, Ms. Okacho, you see that there is a significant number of women that just prefer not to go to hospitals for a number of reasons. Could you explain to us why, in this day and age, there are women who would rather not go to hospital for a delivery, and obviously this, in case of complications, that will not bode well for them?
Yeah, so some of the challenges that were stated or cited were, one, the long waiting times. Also in the advent of COVID, many women are fearful because they fear, because some of the health facilities, they do not have a very good COVID measures in place. They fear that they may contract COVID there. And then additionally is the attitude of the health workers, which has been stated in several studies.
Okay.
And so as a result of them, they would opt to delivering at home. But of course, as we know, given the complications that may arise, and once a woman gets a delay in terms of getting a referral to a higher level facility where she can seek the appropriate health care, then obviously it could lead to a mortality. Another challenge that has also been addressed is, given we know many traditional birth attendants operate in the informal settlements, this has also been a discussion ongoing in terms of getting them also recognized, because they do deliver quite a number of babies in Nairobi. However, they're not officially recognized. And so this has been an ongoing debate because, of course, they've not gone through the traditional channels of training, but they do operate, and women do prefer. And some studies also show the women pay even more to the traditional birth attendant than she would if she would access a health facility.
So rather than go to hospital and deal with the attitude of perhaps a medical service attendant, one would rather pay more to a traditional birth attendant who's not all that trained. Please explain this to me and to the viewers, because I mean, when you had these conversations with the people, explain to me what sort of examples they gave of their experience that would have them completely just stay away from hospitals.
So this has been covered a lot, you know, the examples of being abused physically. Of course, service starts at the gate. So, you know, if the askari even at the gate is not showing you even where to go. Some respondents also cited what they had seen, some of the examples at Pumwani, and also the case at Mama Lucy really was not a good experience for them. So I think also, given that we're in a pandemic right now, people are quite fearful and a lot of misinformation ongoing. And one of the tools that we actually shared with them was the service charter by the Ministry of Health, which also looks at values such as accountability, transparency, timeliness, honesty. And many respondents were actually shocked that the health facility staff do have a duty to take care of each and every client, and that service actually starts from the gate.
Right.
So when we had the Ministry of Health people also in the conversations, they did admit that there are some issues and that we need to actually start enforcing some of these guidelines to ensure that women get quality and affordable health care.
Okay. Now, Peter, to play devil's advocate, you wouldn't always blame some of these medical service providers for not being in the best of moods, given what has been making headlines over the past few months even. Some of them are losing their lives because they're on the front line. They are basically the soldiers fighting this war against COVID-19, and we do know that PPE was not being availed to them as it should be. So what did you discover on the flip side of this conversation on why some of these people might not be in the best of moods, let's just put it that way, when attending to some of the clients?
Yeah, we, as much as they have sworn to protect life and to work around life, they also have life. And as I mentioned, the first challenge that we found from them is being overworked. If you have a facility that has 2 nurses, let's take a facility in Dagoretti that has only 2 nurses that is seeing 120 women every day, then the 2 nurses cannot manage those staff. By the time, the requirement is that at least a nurse should handle at most 40 clients in a day. So handling anything more than that will lead to fatigue, and of course fatigue leads to anxiety, and they can be reactive to these kind of things. Then the second one is structural, because let's say there is an on-job training that is ongoing in a facility. The same nurse has to go for that training. The same nurse has to go to take reports to Nairobi at the same time. So you will not find them at the facility, and we blame them sometimes because we don't find them at work, and they have just been called to do another role. The third one was security, as I had mentioned earlier. Health workers said that some facilities are 24-hour, but then they cannot work 24 hours because who will walk them out? And one of the shocking things is that health facilities are not manned by armed policemen. They are armed by ordinary watchmen. And a health facility is a security issue. And a health facility has a lot of equipment and a lot of commodities that are very expensive. And this also leads to corruption and things being stolen from the facilities, because then we have very poor security for our health areas.
Yes.
And of course, with COVID, we have seen them not getting PPEs. One of the health workers from one of the facilities I won't mention said that her weight, she's a bit bulky in form. So she's not able to fit in the PPEs that were sent, because all the PPEs are structured for one kind of a person, 5'6", and a certain weight.
So if you're tall or bigger,
Sorry?
So if you're tall or bigger, then you're left out of that bracket. You won't be able to protect yourself.
Yeah, anybody taller than 5.8 will not fit in the PPE. Anybody who is bulky will not fit on the PPEs. That has been a challenge. And you know, the national government keeps insisting that health workers, counties should buy the PPEs from KEMSA and the rest. If you look at other counties, because we did comparison, some other counties bought their PPEs from other private providers and they got the right PPEs. So there is also that challenge of them being pushed to buy from KEMSA, which a lot of them don't want. They want to go buy at Meds or buy at other providers who are making PPEs. So those are some of the challenges that they face, and we understand that that's why they are not able to deliver optimally.
Yes, as we would hope. Now, Ms. Akacho, let's talk about the numbers. If we were to get, as we wind up this conversation, if we were to get to a place where they have the right numbers, perhaps not overburdened and perhaps functioning better because they have all they need, how many more would you say are needed in the hospitals in Nairobi?
Numbers, are you talking about health workers?
Yes.
Sorry, I didn't get it. Okay, so I believe, as Peter had mentioned, I think we have just over 5,000 staff that have been targeted in the upcoming annual work plan. And currently we have around 3,500. So there's a gap of around 1,500.
Right.
And we know the majority are technical staff who are nurses, clinical officers, and medical specialists. However, there's also a gap in terms of the specialists. So we do believe that there is opportunity, as we know, with the strike going on, there is opportunity for debate. And we do know that many of our professionals in Kenya are trained. So it's just a matter of listening to some of their grievances and also going to the facility and seeing what they have to deal with on a day-to-day basis, because it's not easy. I was actually at a health facility last week, and you can actually see people are physically and mentally exhausted.
Yeah.
Yes. So for Nairobi, I would say the gap is around 1,500.
1,500 more. And of course, when you look at the larger surface area of the country, then we would need even more. So as that unfolds, those are some of the facts on the ground. Thank you so much to Peter Ngure, who is a policy and advocacy team leader when it came to this particular report, and a contraceptive lobbyist, as well as Akacho Ekirapa, senior reproductive health advisor when it came to this team. Thank you so much for being a part of Morning Express and shedding some light and bringing context to the discussion on the situation of health. Brian George, our reporter, is on the ground at Machakos Country Bus, and he is taking a look at what's happening right there. The traveling for these festivities in upcountry are ongoing. People are stuffed there. The fares have doubled. So he shall be giving us more on what's happening on the ground as far as that is concerned. Stay tuned to more on Morning Express.